Can I confirm that you can see my slides, Ray?
I can't.
Okay. Apologies.
If there's a problem, Jane can share them.
Yes, I might need you to do that, Jane, please. Sorry.
Liz, are they the same ones you sent yesterday?
That's right. Yes, please. Yeah. Apologies for technical issue immediately.
Yeah, just opening. Okay, can you see those?
I can.
Yeah.
Yes, thank you. So yes, thank you so much for having me and inviting me to come and talk to you all today. My name's Liz. I am a cancer nurse. I work in Mid and South Essex, but for the last 2.5 years, I've been leading the programme for the East of England Cancer Alliance to implement genomic testing essentially for all eligible patients with cancer across our region, which has been a huge project and task. But today I've been asked to talk to you about how we use DNA and our genomic profile to inform our, number one, our cancer diagnosis, and two, our treatment options. And I'm also going to touch on looking for cancer predispositions in our population. Next slide, please, Jane. So this is us. I just added some photos there because it's always nice to get a visual. As I say, we are all oncology nurses. We have all worked with patients who have had a diagnosis of cancer, and we all have extra qualifications in talking to patients about genetic testing and what that means for patient treatment and pathways. So we came together and started our programme from scratch in 2024, and you can see there all of the aims and objectives that we have tried to deliver over the last couple of years. Next slide, please. So why are we here and why were we formed by the Cancer Alliance? You may or may not know that the National Cancer Plan that was published earlier this year in February time talks quite heavily around genomic testing, specifically mainstreaming genomics, and I'll come to what that means. It talks about genetic testing and making genomic informed decisions for every cancer patient, so that if you are diagnosed with cancer, you will have a choice to receive a comprehensive genomic analysis that will both guide your treatment options and also give options for your family to have additional testing should that be needed. And that's also integrated throughout the 10-year health plan that was published at the end of last year, Fit for the Future. In fact, there's a DNA helix on the front. So it's very heavily infiltrated through all of the current national cancer plans over the next 10 years. So although it's something that's been around for a long time, genetic testing, and you would have heard genetics and genomics in your everyday life, it's very heavily implemented through national policy as we stand. Next slide, please, Jane. So just to give you an oversight as to how this works across the UK, it's a bit of a complex way that things are set up, but we are set up into 7 different patches. So each of those colourful parts on the map represent what we would call genomic medicine service. And the genomic medicine service is responsible for having a genomic lab that delivers the tests for your hospital site, wherever you receive your treatment and care. And they are also responsible for educating the workforce and making sure that the test directory, which is that document on the left, is kept up to date with all of the relevant available tests for patients. So this is updated regularly, almost every 3 months at the moment, because as science develops and cancer research develops, cancer researchers and scientists and those amazing people that we have in our population can apply to the National Test Directory to add a test in there, because they have proven that that's going to benefit patients. So that is ever evolving, which has made our programme even more exciting than it already was, because we have to keep up to date all of the time with what's available to patients. So at the moment, there's over 200 cancer tests available in there. And in the non-cancer world, there are over 7,000 different tests that you can order for patients in rare diseases such as Huntington's disease and so on. So to deliver that across across the country and across the east of England, we have to be really careful and sensible about how we are going to do that in terms of delivering that through our workforce, to make sure that every single patient that comes through the door with a cancer diagnosis is offered the right test at the right time. Next slide, please. And this is where we talk about, and this is where mainstreaming comes into practice. So mainstreaming is essentially bringing that test and that information to the front line, where you have cancer nurse specialists, oncologists, surgeons, clinicians, those members of staff that meet patients when they are being diagnosed with cancer, when they are being discussed in MDTs, and when you meet your consultant or clinical nurse specialist. In an ideal world, and this is what we are trying to achieve, they will have full understanding of what genomic test is available to you and how that can be delivered to you, and will be able to offer you that test on site. So it's about taking a consent with you in practice, in clinic, when you're consenting for your treatment. And it's also about understanding what that means for your family. So it's moving away from the traditional model of referring everybody to clinical genetics, waiting a number of months to see somebody because there are just so many tests available now and not enough clinical genetic colleagues to be able to provide that service, and bringing it into the mainstream where we can all share practice and support patients in the best way possible. Next slide, please. So I'm not going to go too heavily into the science because I appreciate it's an evening time and that's not what we want to know. But it is really important to understand how DNA works and how this is important to prescribing and understanding your treatment options and options for your family. So you may have heard the terms genetics and genomics. They're slightly different. So genetics is the study of the genes that are passed on from our parents to ourselves and then on to our offspring. I'm going to come to that in a few more slides. And genomics is the study of our entire genome. So all of us on the call, we all are a human genome, and we are all actually 99.9% identical, but it's that 0.1% that makes us different. So it's that 0.1% that affects the colour of our eyes and the colour of our hair, and more importantly, how our cells behave and function, and whether we are individually more susceptible to developing cancer to the next person. So that's the bit that we need to focus on. And over the next couple of slides, hopefully I'll be able to summarise that for you in a more understandable way. Next slide, please. So I can't take credit for this. One of my colleagues came up with this metaphor, but I think it's really cool. It sort of explains it really well. So essentially, your DNA is the cookbook. So in your cookbook, you have your chromosomes that hold your DNA. Then the recipe in the cookbook is the gene. So the gene is within the DNA, and for a gene to function, you need all of the moving parts, and you need it to be intact and not have any what we would call mutations. And if that's working correctly and there are no problems and you have a normal functioning gene, that gene produces what we call a normal protein, and that directs your cells how to function. So it knows, it directs your cells how to multiply correctly, and how to die correctly when they need to die. And that's happening all the time in your body. There are cells multiplying and dying all the time because that's the natural process of the human body. So in the next slide, what happens when an error occurs? So exactly the same, the cookbook doesn't change, but the recipe gets slightly confused. So what can happen in your DNA is that there can be a fault in your gene, and I will come to that. You may have heard of the BRCA gene and genes that cause a condition called Lynch syndrome. I will explain more in detail about that. But what can happen is if you've got a fault in the gene, the recipe gets a little bit mixed up, and instead of creating a cake, you create an omelette because the protein isn't normal, it's abnormal, and then that gives the wrong signals to your cells, and then the cells multiply either incorrectly or over correctly, and that's where you develop a cancer. So I'm hoping that that's made a little bit more sense. So how do we turn those mistakes into solutions? This is the important part. So in the world of genomic testing, there are a number of different ways that patients can have a genomic test, and that depends on what type of cancer you have and how that's going to benefit you in terms of treatment options. So your oncologist will know exactly what you are eligible for, and this could be a mixture of these tests, or it could be one of these tests. You can have a germline test, which is just a simple blood test, and that looks for what we would call gene mutations, so a mistake in your genes that you have inherited from a parent. You may not know that you've inherited that, but when you are diagnosed with cancer, in some cancer diagnoses, you are eligible to have that test done to see if there has been a reason why you've developed cancer that you didn't know about. There are lots of what we call somatic testing, which is tissue testing that happens, and that happens behind the scenes. That's not something that's always discussed with patients because it's part of the diagnostic process. But what will happen is in the pathology lab under the microscope, we can tell whether your tumour or whether the cancer under the microscope has any of its own mutations. And if it does, what that means is that sometimes you're therefore available or eligible for immunotherapies, different targeted treatments. And in fact, what the pathologist can tell us is there's a specific target that you can use here. If you use this drug, the patient's going to have a much better benefit. And that's why it's so important that we continue to test under the microscope, and that's happening on a reflex basis all of the time behind the scenes. And then most recently we have liquid biopsies, so that's also known as ctDNA testing, and that's available at the moment in lung cancers, in breast cancers, and most recently in cancer of unknown primary. Just last week that was added to the test directory. And what that means is if you are struggling to access tissue for a patient, to have all of these tests done, you can take a blood sample and the genomic lab and the scientists there can look for circulating tumour DNA to print out a group of actionable targets that you can then target your treatment to. So it's just amazing science, and this is what we've been trying to work through as a programme, is bringing that amazing science and development into practice for patients to benefit in the cancer setting. Next slide, please. And then this is sort of what we would call the bee's knees of genomic testing. Whole genome sequencing is also now available to patients, where you can take tissue from a patient that is fresh tissue. It goes off to the genomic lab with a blood sample, and they will check your whole genome. So they will be able to give a printout from top to bottom of that patient's genome to be able to tell you the full blueprint of that person, all of the tissue and what we call somatic targets that can be used, whether there are any germline cancer predispositions that have caused the cancer, and whether that patient's family needs any further testing. So this covers everything in one go, but it's not available for all cancers, and it is a slightly more complex process for hospital trusts to use. That doesn't mean that we're not using it, and we've worked really hard to make sure that all of our hospitals in the east of England can access whole genome sequencing, and I'm determined that they will before we end in programme next year. Next slide, please. So thinking about cancer predispositions, so what I mean by that is detecting a syndrome in a patient who may not realise they had that, that has caused their cancer or contributed to causing their cancer. There are two main predispositions that we think about when we're looking for concerns, and one of these is the BRCA gene, so otherwise known as the breast cancer gene. We all have a BRCA gene. This is important to understand, but not all of us have a BRCA gene that's working effectively, and Caroline, when she gives her presentation, will come to that. So BRCA genes are what we call tumour suppressor genes. So they suppress tumours from growing effectively, and if they're not working properly, then cancer is inactivated and your cancer can develop more quickly. So it affects around 1 in 400 people in our population. It is not gender specific. So although it's titled the breast cancer gene, it's also very common in ovarian cancer, prostate cancer, and now lots of research is pointing us towards pancreatic cancer and stomach cancer as well. There are two types of BRCA alterations or BRCA genes, BRCA1, BRCA2, and depending on what cancer you have, you are more at risk of one or the other. And there are also population groups in our communities of if you are of Jewish origin or if you have a family history in the Shetland Islands, you have actually a 1 in 40 chance of having a BRCA mutation compared to 1 in 400. And because of that, the NHS delivered a programme called the National NHS Jewish BRCA Testing Programme that ran for 2 years and came to a close at the end of last year. It is, however, reopening in September. And what that programme allows is for anybody who has a Jewish origin, who has at least one grandparent of Jewish origin and is over the age of 18, you can apply online yourself. You don't need a GP or medical referral, and you will be sent a swab kit in the post to test yourself. So it's a really amazing programme that has picked up many BRCA carriers in our population. Next slide, please. One of the other cancer predispositions that we look for in our population when we're testing cancer patients is Lynch syndrome. And this is an inherited condition that runs in families as well. It's around 1 in 278 is the current statistic for patients that have Lynch syndrome, but actually only 5% of that number are aware that they have it because it's not quite as familiar as having a BRCA mutation. So we're working really hard to make sure that this is publicised and that patients are being tested for this. And in fact, in endometrial cancer and colorectal cancer, what happens is automatically the tissue is tested for what we call mismatch repair gene deficiency. And if that is in place, you are eligible for a test for Lynch syndrome. So what we've worked on quite heavily with clinical teams is to ensure that those patients that are mismatch repair deficient are being offered the blood test for Lynch syndrome. And that's really important because there are so many options for patients with Lynch to reduce their risk of developing cancer, one of which is to take 75 milligrams of aspirin every day. They would also be referred to the bowel screening colonoscopy programme, and they would also be, if you were female, referred to a gynaecologist to talk about having a hysterectomy. So there are many options both for BRCA carriers and patients with Lynch syndrome. But the most important thing is for clinicians and for nurse specialists in the workforce is to identify these patients in our population. And we can only do that by testing patients that have been diagnosed with cancer. Next slide, please. So just a little bit about inheritance, just to be clear, all of these predispositions are not gender specific. So historically, I think BRCA testing was very much a women's test. It's definitely not. It can affect boys and girls, male and female, and it's not age specific either. So if you have a parent who's diagnosed, if I was diagnosed with a BRCA alteration, both of my children each would have a 50-50 chance of inheriting that, and my siblings would be able to be tested because they or may not also have that. So it's what we call autosomal dominant inheritance pattern. Next slide, please. So what does it mean for you and your family? There's lots of questions I put on here, and I'm sure that hasn't even covered the questions you may be thinking of now. But these are the sorts of things that I would suggest you thinking about. Was testing offered to me when I was diagnosed with cancer? And if it was, that's fantastic. And if it wasn't, it's quite possible that you weren't eligible, but it's worth asking that question. Do you have a family history of family members who were younger when they were diagnosed, or were you particularly young yourself at diagnosis? That would be what I would call a red flag to ask the right questions. And is your family at risk? So if you are diagnosed with a cancer predisposition, yes, your family potentially could be at risk, and that's why we would we would recommend that they are tested. And how do you ensure that you're tested? Absolutely talk to your GP, or you would talk to your clinician, and make sure that you are referred to the right people, and to make sure that that's happening. And then you can consider reducing your risk or your family's risk of developing further cancers. Next slide, please. So what this slide represents is the National Inherited Cancer Predisposition Register, which is a long title. This was published in August of last year, and what this holds is a registry of all patients across England who have been diagnosed with a cancer predisposition, whether that be BRCA or Lynch syndrome or one of the other rarer ones that I haven't gone into today. And the most important directive really in the national policy that I mentioned right at the beginning is to increase the numbers of patients and people in our population that sit on this register. So the more people we know about with a predisposition, the more people we can offer screening to, and then in turn prevent further cancers from developing and happening. So it's really important that we continue to push for testing at diagnosis, and then family testing, and then moving into the screening and prevention phase. So I know the numbers on this register are going up regularly, but hopefully we will be able to add to that across the east of England. Next slide, please. So applying all of this to practice, just going back to what we've achieved as a programme and what we've tried to achieve is to, as you can tell, it's quite a complex topic. Number one, it's also something that is ever changing. Number two, so that's really hard to keep on top of. So what we've done is create toolkits for our clinical colleagues who are working on what I would call the front line. And in those toolkits, there are guidelines and flowcharts and patient information leaflets. And really, our main aim from day one is to simplify as much as we can so that testing is offered to patients at the right time, and that no patient is missing out on a test that they are eligible for. Next slide, please. So in summary, genomics is transforming cancer treatments. Absolutely. It's really important that the tissue is tested immediately and the oncologist knows exactly what they're able to offer patients. Genomic testing in the germline setting, so taking a blood sample from a patient that's eligible, leads to increased surveillance and screening for our population. Our message is all around education and awareness, and that's absolutely key for delivering that national agenda that was set by NHS England. And as a service, we are here to support the workforce to deliver that agenda. I appreciate that's lots of information, and more than happy, as Ray said, to take any questions.
Thank you very much. Can we move on now to Caroline, who will talk about her experiences in relation to genomic testing?
Thank you. So my name is Caroline, and I'd like to thank the East of England Cancer Alliance PPG group for inviting me to speak today. I'm a passionate advocate within the BRCA and high-risk communities, as I know this can be, for patients, a very lonely path to travel, and that one that many GPs may not encounter during their whole career. I feel that patients have a huge role to play in advocacy and education, and that's what brings me here today. I carry a BRCA2 mutation. It's more specifically 6172DELT. So I have a deletion of thymine at 0.6172. Probably not very useful information for the majority of the population, but something that has changed my life significantly. So it was something Jane said to me last week when we were preparing for this that has stuck with me, that I wanted to start with. And she said that carrying a BRCA mutation isn't just about having cancer. And that's really, really true because I've never had cancer. And lots of us are lucky enough not to have had cancer, but to find out through family history that we have a predisposition to developing cancer. So I have a fear of developing something that I may never develop. And living with that is really hard. It's a fear that you can't explain to people who aren't in your situation. Those of us who don't find that we have a mutation by way of a cancer diagnosis find ourselves somewhere on the outside. We don't really belong anywhere. We don't like to, in inverted commas, waste cancer charity resources because we don't have cancer. So we're in a kind of limbo. So my story began in 2002. My paternal aunt, who was in her 70s at the time, was diagnosed with ovarian cancer. And because of the type of ovarian cancer she had, the fact that her mother, my paternal grandmother, who died before I was born, had been diagnosed with breast cancer at the age of 48 and had died by 58. And crucially, the fact that my family are of Ashkenazi Jewish descent. So Liz mentioned that the Ashkenazi Jewish population has a higher prevalence of people who carry a BRCA mutation. So Ashkenazi Jews are Jews that come from Poland and Eastern Europe. So we carry this higher risk of BRCA mutations. And also there are Jews from Sephardi and Mizrahi descendancy that are also at high risk. So when she was diagnosed, she was offered BRCA testing because of these issues. And it came back that she carried one of the 3 Ashkenazi Jewish founder mutations. Now, she was very clever. She realized that this was very, very important information that needed to be shared with the family. So she shared it with my dad, her brother, and to me and my sister and my 2 half sisters. So my dad had 2 daughters from a previous marriage, and then my sister and myself from the current marriage. Now, it was 2002, and it's what I call the dark ages of BRCA mutations. BRCA2 had only been discovered in the late 90s. We didn't understand what her mutation meant to us. Why is that anything to do with us? What's the significance there? So I have to admit, we ignored her. She was rather bossy and very persistent about sharing this information. She would call my dad, she would call me. Eventually, she got the Royal Marsden Hospital where she was being treated to send us a letter to take to our GPs asking for a referral to the genetics centre. So I went to the GP in 2006, armed with my letter for the GP. The GP took it from me and he read it. And he said to me, so who in your family's had breast or ovarian cancer? So I told him about the family history, the fact that we had an identified BRCA mutation in the family. He said, I've just been on a course about this. And I thought, amazing, I'm in great hands here. He said, I don't think you'll have one. So go home and stop worrying about it. So I did. He's the man who'd been on the course about it. He knew what he was talking about. Off I went. It hits June 2007, and my auntie passed away. Her ovarian cancer had spread. She was very, very poorly. And 10 days later, my beloved dad died of lung cancer. Now, he hadn't told us he had lung cancer, very typical of my dad. He liked to keep things secret. And it was after he died and I was at my mum and dad's house that the phone rang and somebody asked to speak to my dad. And we said, really sorry, he's passed away. Can we help? And it turned out it was a consultant geneticist from the Northeast Thames Genetics Service. And my dad had gone in secret to have BRCA testing. So he tested positive. So the consultant said, does he have any children? So my mum said, yes, he's got 2 daughters from a previous marriage and 2 from our marriage. And the consultant said, right, they all need to be tested. So my 2 half sisters were dispatched off to one genetic service, and my sister and I were sent to the one where my dad had been tested. Now, we were tested at Great Ormond Street Hospital. At that time, my son was actually in cardiac critical care on the 4th floor. He just had open heart surgery, and we wandered down to the ground floor to have our testing. So we walked in, our minds were elsewhere, obviously, and we still didn't understand what a BRCA mutation was. We sat down, the geneticist said, right, so someone in your family has a BRCA mutation. If you test positive, you have an 85% lifetime chance of breast cancer and a this percentage chance of that cancer and cancer. And we were like, okay. And he said, would you like to give a blood sample? And in my naivety, I thought, what difference is a little vial of blood going to make to my life? Well, that was a very naive decision on my part. Gave my blood sample. 6 weeks later, I was called back. My sister and I, my sister from this marriage, the current marriage, and I both tested positive, and the two half sisters had tested negative. We were like the perfect 50-50. So I was 33, my sister was 29. There was no screening at that time for women of our age. So we were sent away. Now, imagine being told you've got a 85% lifetime risk of breast cancer, but being told, don't worry about it and come back in a couple of years. That's what I did. Thankfully, I had small children to entertain me. I came back and I had screening on the NHS, mammogram and MRI. Came back with shadows on both breasts, and I was convinced I was going to die. It turned out that that was because of where I was in my menstrual cycle, and no one had thought to ask me. So I'd had to wait for an ultrasound to find this information out. And that's what cemented my decision to have a risk-reducing double mastectomy. I couldn't live with scanxiety, as people call it, waiting for the next scan and hoping that there is nothing there. So in 2009, at the age of 35, I had my perfectly healthy breasts removed and replaced with permanent expander implants. Then at the age of 40, after I'd had my fourth child, I had my ovaries and fallopian tubes removed. Now, this was a much harder decision for me because breasts to me were there to feed my children, which they had done, and ovaries were there to make me a woman. They were like the essence of being feminine and female, and I was terrified that I was going to lose that. There's no counselling. You're just sort of sent off to have bits removed and then given HRT. Luckily, I didn't have any horrible adverse reactions, but it was a very, very difficult journey. You're plunged into surgical menopause, and at the age of 40, that isn't ideal for so many reasons. In 2018, after I'd had my implants for over 10 years, I had a little bit of a scare with what's called breast implant associated anaplastic large cell lymphoma, which is a cancer that can be caused by the implants. So ironically, the implants that I had put in to stop me getting cancer had potentially caused me cancer. So more stress. Went through a lot of tests that were inconclusive, and the only way to find out whether I had it was to have my implants removed. I had them removed and I didn't have the cancer, luckily. So I have remained flat after that because I can't cope with the thought of a cancer occurring and I don't know about it, or the worry that I'm going to have them replaced in however many years' time. So I have 4 children. My children are currently 22, 21, 18, and 13. They can be tested at 18, but none of my children have tested yet. And that is something that I agree with. I don't believe at such an early age it's necessary for them to be tested. They're not at a high risk of developing cancer at those ages. And I feel that it's too young for them to live with that hanging over their head. I have been very, very open and honest with them throughout my whole journey. They've seen me go through surgeries. They see me talk about this in the media and anywhere where people will listen, because I believe it's really important that they are educated and they know what to do if and when they test positive. So for me, this has been a long and hard journey. However, I feel that my dad left me the greatest legacy, which was the gift of knowledge. Do I feel resentment towards him? Not at all. Do I feel guilt that I may have passed it on to my children? Not currently. That may change if and when some of them test positive for a BRCA mutation. But the thing I'll leave you with is what my consultant geneticist said to me in an appointment. He said, Caroline, everyone carries a genetic mutation, but you're lucky you know what yours is and you can do something about it. And that has stayed with me to this day. So although I have walked a difficult path and that will continue with my children, I feel lucky to have this knowledge and I feel empowered that I've been able to do something. So thank you very much for listening.
Thank you, Caroline, and indeed, Liz. Both brilliant presentations, and I'm sure people have learned a lot. But now it's over to Jane to moderate the questions which are in the chat.